All right, so good evening, everyone. So am I audible to everyone? So just please respond. Am I audible to everyone? Okay, so very good. But anyways, there is a lot of gap. I mean, there is a lot of a delay between what I am speaking and between the what is being relayed or broadcasted. So just please don't mind if there is a delay in my teaching and as well as you answering. So it doesn't mind. Okay, so let me start the this session now. So this particular session, I'm just doing of the general medicine questions of the FMGE exam, which has been conducted on the August 31st, right? So I definitely consider the exam was completely a nightmare. But I definitely also can say that that is not the type of questions which have to be given for you for the purpose of screening. So I really feel pity and as well as sorry for all of the FMG students who have attended this particular exam that is on August 31st of this particular 2020. Okay, but anyways, we have to be very strong enough to go forward, right? We will fight for it definitely. We're all there for you to support you, right? And along with not only the faculties, the Arise Medical Academy is definitely there for all of the FMGE students. So please take this point into consideration. You can approach us at any point of time regarding this particular issue for your support, right? So myself and as well as Dr. Khalil are very much there for you all right? Okay, so with this basic introduction, we will just go ahead with the questions which have been asked. So first of all, I should thank Mr. Student Raviteja, Prashana, Isha, and as well as Omkar. These are the 4 students who have given me, I mean, in the sense they tried to recall, they have helped me a lot, right? They have helped me a lot in recalling the questions. So I should definitely thank these particular students for giving me a recall, right? And let me tell you, this is completely a recall, right? And this particular recall may be incomplete as well. So some of the questions I got, because the problem like what we had was the questions were very lengthy questions, right? And it is the first exam like where the exam was in such a way that even though we contacted nearly around 100 to 150 students, the entire recall was unable to get. We were unable to get all the questions from pin to pin and as well as option to option. They said like, sir, we are unable to recall the questions, right? So I definitely understand the strength of the questions by saying that we are unable to recall completely. Okay, right. And the other important thing is the images which have come in your exam may not correlate in my session whichever I am conducting now, because what the students have said is they have said ki, sir, they have given a picture of rod spot, they have given a picture of Janeway lesions, and they have asked like what is the abdominal finding. So then I have got the picture of rod spot and as well as Janeway lesion and incorporated into my presentation, and accordingly I'm just trying to give you the explanation for those type of questions. Okay, right. So with this basic introduction, we will just go ahead with the questions which have been asked. Now you take the first question, right? So this was one of the question. Sir, in one of the question, they gave a patient had history of syncopal attack and diagnosed as a case of the aortic stenosis. Which of the following features will you see on the X-ray? The PA and as well as lateral view were given, right? Okay. So this is your PA view and this is your lateral view, right? So now what are the findings in case of the aortic stenosis chest X-ray? This was the question asked. The options were post-stenotic dilatation of the aorta, dilatation of the aortic valve, and as well as the widening of the aortic knob. So can anyone tell me, like, what did you answer and what is the answer? Right. So the answer to this particular question is the post-stenotic dilatation of the aorta. That is the answer to this particular question. Right? Very good, Aishwarya. So you have answered it first. Very good. So it is the post-stenotic dilatation of the aorta. I will just show you a correlate. And many of the students were asking me about the third option, that is widening of the aortic knob. Widening of the aortic knob, you will see in patients with the aneurysm. Right? You will see this in patients with the aortic aneurysm, but not in case of the post-stenotic dilatation of the aorta. Right? In post-stenotic dilatation of the aorta is the one which you will see in aortic stenosis, but not in case of the aneurysm. Okay, but anyways, I'll just show you the image now. Now, this is the chest X-ray of a patient with the aortic stenosis. Right, now you see here, and okay, after having conducted, after having faced about the exams where you have completely clinical based questions, let me tell you and let me advise you that please don't depend on cheat codes. Please don't depend on mnemonics. What you have to be dependent on is the concept. See, concept learning is very important. Not learning through cheat codes, not learning through mnemonics. They will not solve the purpose of clearing the exam, but they will solve the purpose of a self-satisfaction that I have remembered the topic. That's all. That will not solve the purpose of your understanding the concept. Please don't do that for your upcoming exams. Okay, it is my sincere advice. You have to learn the concepts, then only you can crack the exam. Okay, so now you can see here, see, this is the aorta, right? This entire thing is the aorta, which is the ascending aorta. So the ascending aorta is abnormally dilated. Where exactly is that? That is your post-stenotic dilatation of the aorta. Post-stenotic dilatation means what? See, here somewhere you have the aortic valve. Above the aortic valve, you can make out the ascending aorta is completely dilated. Whereas the descending aorta and as well as the abdominal aorta, it remains normal. It remains normal. Where in case of the aortic stenosis. So in case of aortic stenosis, what is the answer correct here? Post-stenotic dilatation of the aorta. And some of you are answering about the widening of the aortic knob. Let me explain you about this. Now, yes, see, this is your aortic knob. You see here, this is completely dilated. So this is what is your dilatation of the aortic knob. And where do you come across this particular dilatation of your aortic knob? You will come across this in patients with the aneurysm of the aorta. Right, you will come across in patients with the aneurysm of the aorta. So to summarize everything now, the answer to this particular question is post-stenotic dilatation of the aorta. Now, followed by that, we will move on to the next question. Yes, see, let me tell you, the image which has been given in your exam is not same. Right, image which has been given in your exam is not same. Okay, so just based on the recall, I have collected the image and then I have placed this image for the explanation for you. Right. So can anyone tell me what is this test? Shifting dullness, fluid thrill, check abdominal tenderness, palpation. Yes, can anyone tell me? Very good. So Sai Taruni Danda, right? Very good, Sai Taruni. So the answer is the fluid thrill. The answer is the fluid thrill. Okay. So very good. So the purpose of doing this particular shifting dullness or fluid thrill, that is mainly to check for the presence of ascites. Right? To check for the presence of ascites. Okay. Now you take the shifting dullness. Shifting dullness is being done when the fluid in the peritoneal cavity is around 1000 ml. And fluid thrill is being done if the fluid in the peritoneal cavity is around 2000 ml. Right? I'll show you both of that. I'll show you both of that. Okay. Now, so this is your shifting dullness. Like what we do, initially we will try to percuss from center of the abdomen to the flanks. Right? From center of the abdomen to the flanks. Then immediately what we will do is, we will shift the patient towards the lateral side. Right? We will shift the patient towards the lateral side. Okay. So first in supine position, what will you have? The center will be tympanic. Why? Because there is no fluid here in the center whenever the individual is lying in the supine position. The fluid is accumulated in the flanks and as well as the hypogastrium. So the hypogastrium and as well as the flanks, this will be dull. This will be dull. The center will be tympanic. Now, once you shift the patient towards the left lateral side, what will happen? The fluid which is present here will move to the dependent area. So this area becomes tympanic and this area becomes dull. Okay, so this is what is called as the shifting dullness. And we will do this particular shifting dullness when the quantity of the fluid is around 1000 ml. Right, when the quantity of the fluid is around 1000 ml. All right, next. Now, can anyone tell me what is this? What is this particular sign? This is also being done for checking the presence of ascites. Yes, can anyone tell me what is that? The one which I have put the question mark. What is that particular sign? So this is called as Puddle sign, right? This is called as Puddle sign. Okay, now when will you do the Puddle sign? So you will do the Puddle sign when the quantity of the fluid in the peritoneal cavity is around 200 ml. Right, when the quantity of the fluid in the peritoneal cavity is around 200 ml, then you will do what is called the Puddle sign. Okay, so this is the position when the individual's position is made in the following manner. The entire fluid will get accumulated in the dependent area and this area will be dull on percussion. Right, this area will be dull to the percussion. So that tells that there is nearly around 200 ml of the fluid in the peritoneal cavity. Now, this is what is your fluid thrill. This is what is given in your exam. So the presence of the fluid thrill tells that there is nearly around more than 2000 ml of the fluid in the peritoneal cavity. So your Puddle sign, it can be up to 120 to 200 ml of the fluid is there in the peritoneal cavity. Right, 120 to 200 ml of the fluid is there in the peritoneal cavity. Okay, right. So that completes this particular question. What is this particular test? That is nothing but your fluid thrill. This is one of the questions which has been given in your exam. Right. So this was completely another recall. And let me see you again. The images may not correlate what has been given in your exam, but this is purely based on the recall. Now, sir, they have given the images of rod spots and Janeway lesions and asked what is the abdominal finding of this particular case. The options are ascites, portal hypertension, splenomegaly, lymphadenitis. So can anyone tell me what is the answer to this particular question? Yes, who will answer me first? Okay, so the answer to this, very good. Aishwarya and very good. So everyone is answering now. So Aishwarya has answered first. Very good, Aishwarya. So the answer to this particular question is splenomegaly, right? So splenomegaly. Now, actually, what is the diagnosis here? The diagnosis is, okay, can anyone tell me what is the diagnosis? What is the diagnosis? So diagnosis is infective endocarditis. So in infective endocarditis, like what will be the abdominal finding? the abdominal finding in infective endocarditis is, that is your splenomegaly. Right, it is your splenomegaly. That is the abdominal finding in infective endocarditis. Right, then we will move on to the next question. Right, so it was just a recall. Sir, they have given us a flow volume loop of COPD. Right, I'm not very much sure whether the same image was given or not, but the recall which was said by the students was that, so there was a flow volume loop corresponding to the COPD, chronic obstructive pulmonary disease. So in chronic obstructive pulmonary disease, this will be the flow volume loop. So what is actually chronic obstructive pulmonary disease? It is an obstructive lung disease which is characterized by a decrease in the expiratory flow rates. Right, decrease in the expiratory flow rates. So can anyone recall and tell me, is it the same question which has been asked? So can anyone please recall and correct me, is it the same question which has been asked? Right, so they have asked about decreased expiratory flow rates. So in case of COPD, you will have decreased expiratory flow rate. Now in your flow volume loop, let me tell you, this is the inspiratory component. Right, this is the inspiratory component and this is your expiratory component. Right, this is your expiratory component. So you can make out here your expiration is reduced. Actually you should be having the expiratory curve like this, but you see what is happening here, the expiratory flow rates have been reduced. So the expiratory flow rates which have been reduced, that tells it is a chronic obstructive pulmonary disease or obstructive lung disease. So this is about your flow volume loop on COPD, chronic obstructive pulmonary disease. Then followed by that, yes, this was another very interesting question, and I felt this was a very easy question as well, right? Those students who have followed my lectures, definitely they should have answered. Acha, Taruni, they have given the diagram as an option. Okay, fine. Right, so you see the question, a person comes with the chief complaints of pain on the face when smiling and when he touches the face. What is the medication you will prescribe? Sir, I felt like the question looked like trigeminal neuralgia. This was a recall by one of the students. The options were morphine, NSAIDs, levetiracetam, carbamazepine. So which drug you will give? So for trigeminal neuralgia, let me tell you, no, they didn't mention this trigeminal neuralgia. This was the recall by the student. This sentence was a recall, that's all. I definitely know that they didn't mention the trigeminal neuralgia. Very good. So the answer is carbamazepine. So drug of choice for trigeminal neuralgia is carbamazepine. Okay, next. And if the individual does not respond to carbamazepine, then what we give is oxcarbamazepine. And if the individual does not respond to your oxcarbamazepine, then what we give is baclofen. Right, then what we give is baclofen. So baclofen is the other drug like what we give if the individual does not respond to your oxcarbamazepine also. And we can also give another important drug, that is lamotrigine. Right, we can also give other important drug, that is lamotrigine. Okay, so these are the drugs as a part of the medical management for trigeminal neuralgia. And if the individual is refractory to medical management, right, if the individual is refractory to medical management, that is the point we do what is called rhizotomy. That means we will ablate the trigeminal nerve root. We will ablate the trigeminal nerve root. Okay, so that is about your drug what we give in case of a scenario related to your trigeminal neuralgia. Right, so this was another interesting question. So there was a big lengthy question, it seems almost like 4 to 5 sentences of the clinical scenario has been given, right? But the question gist or summary was like this. An elderly patient with hypertension fell down. His blood pressure was 220 by 110 millimeters of mercury. And a CT scan image was given, sir, that was suggestive of bleed. That was the recall by the student. What will you give? Start antiplatelet drugs. Platelets are transfused even if the platelet count wasn't low. Reduce the blood pressure to less than 120. Putamen is the most common site of hemorrhage. Yes, can anyone answer this question? Right. So let me tell you what exactly is the answer here. See, 220 by 110. What is this? It is a accelerated hypertension. Right? It is an accelerated hypertension. And not only that, the individual fell down. So it is, that means the individual is having some neurological deficit. So it's a hypertensive emergency. Right? It is a hypertensive emergency. Okay. Hypertensive emergency means accelerated hypertension with end organ damage is what is called hypertensive emergency. All right. Now, in those individuals with hypertensive emergency, you have to reduce the blood pressure up to 140 millimeters of mercury, not less than 120. You can reduce the blood pressure up to 140 millimeters of mercury. That is the point there. But in case of hypertensive hemorrhage causing stroke, what is the most common site of the hemorrhagic stroke? The most common site of the hemorrhagic stroke is your putamen. So putamen is the most common site for the hemorrhagic stroke. Right? Putamen is the most common site for the hemorrhagic stroke. Okay? Right? Then how can you make out that it is a hemorrhage in the CT scan? I just show you one image for you. I don't know whether the same image was given or not, but I just wanted to show you a CT scan with pontine hemorrhage. So in case of hemorrhage, let me tell you, you will have a hyperdense lesion. Right? You will have what is called hyperdense lesion. Okay, you see this. This is your hyperdense lesion. Right? Whereas in infarct, what you will have is the hypodense lesion. Whereas in hemorrhage, you will have hyperdense lesion. Okay. So the answer to this particular question is putamen is the most common site of the hemorrhagic stroke in case of hypertension. And in hemorrhagic stroke, how much you have to reduce the blood pressure? You have to reduce the blood pressure only up to 140 millimeters of mercury. You should not reduce up to 120 millimeters of mercury. No, this is an incorrect statement. Right? And when there is a hemorrhagic stroke, how can you give antiplatelets? You should not give antiplatelets in patients with the hemorrhagic stroke. You have to give antiplatelets in patients with the ischemic stroke, but not with the hemorrhagic stroke. Right? So please remember that. That is a very, very important point. Next. So this was another recall. Sir, there was an image of icteric sclera, and there was an image of Dupuytren's contracture, and there was an image of ascites. What is the diagnosis? Congestive heart failure, alcoholic liver disease, cirrhosis of liver. So can anyone recall and tell me what is the answer? Right. So I don't know how many of you are marked for alcoholic liver disease. The answer is not alcoholic liver disease. The answer is the cirrhosis of liver. The answer is cirrhosis of liver. Next question comes, why, sir? Why not alcoholic liver disease? Now let me tell you, alcoholic liver disease can present in three ways. It can present with fatty liver. It can present with hepatitis. It can present with cirrhosis of liver. But he has given the second option as alcoholic liver disease, but did not mention which stage of alcoholic liver disease, right? It can be in any stage. It can, in case of fatty liver, secondary to alcoholic liver disease, you will not have these manifestations. These manifestations are seen mainly in case of cirrhosis. Okay, so when you are having a confirmed option of cirrhosis of liver, right? When you are having a confirmed option of cirrhosis of liver, then go with the cirrhosis of liver. right? Then go with the cirrhosis of liver. The answer is not alcoholic liver disease. He has given you alcoholic liver disease mainly to confuse you. And I don't know how many of you opted for alcoholic liver disease. Alcoholic liver disease is not the answer there. All right. Next. Now let me just move on to the other recall. Right. And I wanted to give you one small advice to all of you as of now, because this is a free session, right? And exclusively conducted by arisemedicalacademy. So let everyone take the advantage of this particular free session. So I suggest and I advise you to forward the link to your respective groups of your friends community. It is only to take the advantage of the recall, right? So please don't mean other way around. It is only to just have a recall. Okay. Right. You see the next question. No, Sai Taruni, the answer is C, cirrhosis of liver. It is not the alcoholic liver disease. All right. Now, we will move on to the next question. A patient suffered from vomiting and diarrhea for past 24 hours. His urine frequency was reduced. What will you find in this patient? Urine sodium more than 40, kidney biopsy revealing kidney damage, hyperosmolar urine, post-renal obstruction. So can anyone tell me what exactly is the answer in this question? Yes, Sai Taruni, like that's what I was telling you, right? They have mentioned it as an alcoholic liver disease, but they did not mention cirrhosis there in alcoholic liver disease. So in such case, you cannot opt for the alcoholic liver disease there. Okay. If in case of alcoholic liver disease, if they would have mentioned cirrhosis, then that would be the answer. Okay. Right. Very good, Satish Dagar, and as well as Mr. John. So the answer is the hyperosmolar urine. Now, how to explain this type of question? See, the patient suffered with severe vomiting and as well as diarrhea. Okay. And thereby what will happen? The urine output has been reduced. So the individual, post-renal azotemia, it's okay, no fine, no problem, Ashwarya, but this will not be the answer anyways. Okay, so vomiting and diarrhea, what it will do? It will reduce the fluid levels within the individual. When it reduces the fluid level in the individual, what will happen to renal perfusion? Renal perfusion will be decreased. So once the renal perfusion is decreased, the individual will land up in what is called renal failure. And this particular renal failure, it is pre-renal type of acute renal failure. Right? Pre-renal type of acute renal failure. And in case of pre-renal type of acute renal failure, if you calculate the urinary sodium in case of pre-renal type of acute renal failure is only less than 10. Less than 10 milliequivalents per liter, where in case of pre-renal type of acute renal failure. And it's an acute renal failure, right? So when it is an acute renal failure, the kidney biopsy revealing the kidney damage will not be so quick. Kidney biopsy reveals the kidney damage or changes in the kidney in patients with a chronic renal failure, not in case of acute renal failure. Now, because the fluid levels have been reduced, renal perfusion have been reduced, what will happen to urine output? That will be reduced. And the urine which is being produced will be of hyperosmolar urine. So the answer to this particular question will be C. Then what is this post-renal azotemia? Post-renal azotemia is secondary to calculi. Right? Post-renal azotemia is secondary to calculi, where the calculi within the ureter, the calculi within the bladder, right? Or it would be secondary to benign prostatic hyperplasia in males, BPH in males. Okay, so that is about what is called post-renal azotemia. That is your fourth option. But what is the answer to this particular question? The answer to this particular question is the hyperosmolar urine, right? So please remember this. The clinical scenario which has been given to you is pre-renal type of acute renal failure. Now, so this was the other recall. So the recall was, sir, they have given an X-ray of hydropneumothorax, right? And they have given the options like, what is the diagnosis of the X-ray? In the sense, they did not give the question like this in a single manner. They have given bit a lengthy question, sir, but I am unable to recall. But the only point was the X-ray which was given, I am definitely sure it was the question related to hydropneumothorax. Now, so you see here, the options which were given was pleural effusion, pneumothorax, and as well as the hydropneumothorax. So this was the options which were given now. What is the diagnosis of the X-ray? See, the presence of straight line or the presence of the horizontal line, right? The presence of the horizontal line, it is very much suggestive of the hydropneumothorax, right? It is very much suggestive of hydropneumothorax, okay? Where the presence of the, what is this horizontal line tells you? See, this is the air in the lung and this is the fluid in the lung. So that air fluid interface in a form of a straight line. And where is that air fluid interface? That is in the pleura, not in the lung. It is in the pleura. So that is why it is called hydropneumothorax. Now, so you may get a doubt, sir, how will be the X-ray in pleural effusion and as well as pneumothorax? I just show you that. Now, this is the chest X-ray of the pleural effusion. Now, I just want to ask you one question. Can anyone tell me what will be the earliest sign of pleural effusion in the chest X-ray? What will be the earliest sign of pleural effusion in the chest X-ray? The earliest sign of pleural effusion in the chest X-ray is blunting of the costophrenic angle. Right? Blunting of the costophrenic angle. Now, what is this costophrenic angle? This is your costophrenic angle. Right? This is your costophrenic angle. All right. Now let me tell you what will be the chest X-ray finding in pleural effusion. So in pleural effusion, there will be blunting of the costophrenic angle and mediastinum is shifted to the opposite side. That is another important point. And you will have a curve. And this particular curve is nothing but your LS S-shaped curve. Right? LS S-shaped curve. Okay. Which is also nothing but your meniscus sign. Right? So that is about the chest X-ray in pleural effusion. And the chest X-ray which has been given to you here is hydropneumothorax. Okay. Right. And this was the other recall. And many of the students have done mistake in this particular question. Right? Many of the students have done mistake in this question. Right? I'll tell you the answer. Sir, they have given an image. They asked the image based question with description like patient has flexion of the hips. Sorry, flexion of the PIP. That is your proximal interphalangeal joint. And there was extension at the dip. There was extension at the dip. That is distal interphalangeal joints. Okay. And which condition is associated with it? Now, let me tell you, in this way, let me tell you again, the image is not same. Right? Image is not same. And I have got I didn't get the proper recall on the image. So first thing, after going through the options, I have asked like how are the nails in the patient? Right? I have asked, can you tell me how are the nails in the patient? Right? They said, sir, nails, we don't remember how they were. Right? Why am I very much concerned about the nails? I am very much concerned about the nails because in case of psoriatic arthritis, you will see the pitting of the nails. You will see pitting of the nails. So the recall did not, the students whom I have asked, I did not get a recall on how was the nails there. Okay. Now, but they said so two hands were given. One right hand was given and one left hand was given. And the changes were there in both the hands. This was the recall what I got. The changes were there in both the hands. Now, where was the effect here? The problem, the pathology was in the proximal interphalangeal joint, and as well as there is extension of the distal interphalangeal joint. Now, what is this suggestive of? If the individual is having bilaterally symmetrical involvement, both right and left hand has been given to you, bilateral symmetrical involvement, you will have that in patients with the rheumatoid arthritis. You will have that in patients with the rheumatoid arthritis. All right. Now, what is this particular sign here? So this particular sign It is your Boutonniere's sign. Okay, this is your Boutonniere's sign, right? Let me tell you again, this is purely a recall. The image is not same, and I did not get a proper recall and how was the nails of the patient, right? And you take osteoarthritis. In osteoarthritis also, there can be involvement of your distal interphalangeal joint. But osteoarthritis, it need not be symmetrical. It need not be symmetrical. It can be asymmetrical also. So if it is symmetrical, involvement of proximal interphalangeal joints and hyperextension of the distal interphalangeal joints, that is what is nothing but your Boutonniere's deformity or buttonhole deformity, right? So please remember this, okay, right? And so this is about the recall of this particular image-based question, right? And one more time, again, I advise you, all of you, so please forward this link to your respective groups of your friends. So because this is a free session, let everyone take the advantage of this session. Because even the December exam, also you can expect, I'm not sure, we'll keep our fingers crossed that the exam paper should not come in the following manner, right? And we, from the faculty's point of view, we will pray for you all to see that the December exam should be very easy for you. Okay. Now, this was the other recall. A patient came with the inflammation of metatarsophalangeal joint. Doctor prescribed a drug which lowers the serum uric acid. And what is the mechanism of this particular drug? What is the mechanism of this particular drug? Xanthine oxidase inhibitors, thymidylate synthase, ribonucleotide reductase, pyruvate carboxylase. Yes, so who will be the first person to answer this question to me? Very good. So Laukik Vemuri has answered this question, right? Very good, Laukik Vemuri. So the point is that there is inflammation of metatarsophalangeal joint. So that is suggestive of your gout. So in gout, the uric acid will be increased, right? The uric acid will be increased. Now you see how is the uric acid formed? Uric acid, it is formed from the hypoxanthine, right? Uric acid is formed from the hypoxanthine. So hypoxanthine is converted into uric acid in the presence of an enzyme called xanthine oxidase. In the presence of an enzyme called xanthine oxidase. Now, in patients with the gouty arthritis, you want to reduce the uric acid, right? You want to reduce the uric acid in patients with the gouty arthritis. So what you will do, you inhibit this enzyme. You inhibit this enzyme, xanthine oxidase. And for that, what will you give? You have to give allopurinol. Right? For that, you need to give allopurinol. So allopurinol will inhibit this enzyme xanthine oxidase. So once it inhibits the xanthine oxidase, the uric acid synthesis does not occur. So the answer to this particular question is your allopurinol which is being given to you is your xanthine oxidase inhibitor. And this xanthine oxidase inhibitor, that like what all we have, one is your allopurinol, and we have one more drug, that is febuxostat. That is your febuxostat. Okay, so these two are the xanthine oxidase inhibitors, which are used in the treatment of your gouty arthritis. Right. So this was the other question. This is another important question where many of the students got confused. And I'll tell you in a very beautiful way, and I'll give you a very strong reference that is from Harrison, recent edition of the Harrison. I'll quote the reference also. Okay. Right. So patient presented with chest pain and diagnosed as angina pectoris. His blood pressure is 150 by 90 millimeters of mercury. Which antihypertensive drug is the first choice? Right? Which antihypertensive drug is the first choice? Amlodipine, thiazide diuretics, atenolol, ACE inhibitors. So which antihypertensive drug is given as the first choice in the individual? So who will answer this question first? Okay, so Satish Dagar want to give AC inhibitors. Okay. Any other answer? Laukik Memuri want to give amlodipine. All right. Any other? Very good. So Pia Web Purohit, right? Purohit has answered this question correctly. The answer is beta blockers, and that too. Yeah. So Aishwarya, right? Very good. So if anxiety attacks is also added, then it makes my answer a bit easy. The answer is selective beta blockers. Sir, where is the reference from? I'll give you the reference. The reference is from Harrison 20th edition. Okay, you see here. Now, the blood pressure is 150/90 and the individual has been diagnosed angina pectoris. So why does the angina pectoris occurs? Angina pectoris, one of the very important causes secondary to coronary artery disease. So in coronary artery disease, what will happen? The demand is more. The demand of the blood supply will be more and supply will be less. In angina pectoris, what will happen is the demand is more, the supply is less. Okay, so when demand is more and as well as supply is less, what you have to do? You have to reduce the demand. Right? You have to reduce the cardiac workload. Reducing the demand means reducing the cardiac workload. So how will you reduce the cardiac workload? You have to reduce the heart rate of the patient. How will you reduce the heart rate of the patient? Give beta blocker. And the same beta blocker should also be given to reduce the blood pressure also. Right? So now let me show you the reference of this. Now, so this is the table from Harrison. Right? Harrison 20th edition. You see now. So beta blockers like cardioselective beta blockers like atenolol and as well as metoprolol can be given. And the indications, see, actually these are the drugs for hypertension. These are the drugs for hypertension. The entire list of drugs, that is diuretics, beta blockers, alpha antagonists, sympatholytic agents, ACE inhibitors, all these. Now, this group of antihypertensives should be added depending upon what is the underlying risk factor. Right? I can tell you, I mean, this is a completely a crowded slide. You may not be able to make out the individual table, I mean, individual letters or words, but let me tell you that the same table is from the Harrison. Okay, so cardioselective beta blockers should be given in patients with hypertension in angina. Right? Should be given in patients with hypertension with angina. Okay, so the answer is beta blockers, that is atenolol. All right, next we will move on to the next question. Right, so this was the other recall which was given by the students. So the recall was saying the following: a patient came due to heart pain, or I mean to say chest pain. His neck veins were engorged, blood pressure was less, and heart sounds were muffled. See, this point whether given or not given, I don't know, because some said that this point was given. Some students say no, it was not given. Right? I am not sure about it. X-ray image was attached. Now, even the X-ray I have tried to inquire. Please tell me, is this type, did the X-ray look like this for this clinical question? Did the X-ray look like this for this question? If the X-ray which has been given to this particular question was similar to that of what I have shown, then the answer was the cardiac tamponade. Right? Then the answer was the cardiac tamponade. So please remember that cardiac tamponade, it is characterized by what is called Beck's triad. Right? It is characterized by Beck's triad. So what does the Beck's triad show? Beck's triad, it will be, you will have hypotension, you will have engorged neck veins, right? Engorged neck veins, and you will have what is called the heart sounds being muffled. Right, heart sounds being muffled. So this is what is your Beck's triad. This is what is your Beck's triad. All right. So this is very, very important point. Now, what does the chest X-ray shows? The chest X-ray, whatever you are having, like there is cardiomegaly with cardiac silhouette. Right, with cardiac silhouette. Yeah. So the diagnosis to this particular question was cardiac tamponade. Diagnosis to this particular question is cardiac tamponade. All right. Next. Now, this was the other recall. A woman came with history of fatigue. On blood examination, there was macrocytic hypochromic anemia. On further examination, she has increased homocysteine and normal methylmalonic coenzyme A levels. What is the diagnosis? Now, the options given was folic acid and B12 deficiency, folic acid deficiency, B6 deficiency. Can anyone recall and tell me what is the fourth option? Can anyone recall and tell me what is the fourth option? The answer definitely to this particular question is the folic acid deficiency. I will also explain you why. Hyperhomocysteinemia, it could be due to three reasons. Okay, so hyperhomocysteinemia can occur due to folic acid deficiency, it could be due to B12 deficiency, and it could also be due to B6 deficiency. But the point here is the answer is not B6 deficiency. The answer is not B6 deficiency. Now, why? The reason is that the blood picture was showing macrocytic hypochromic anemia. Now, where will you have this macrocytic hypochromic anemia? You will have this in patients with the folic acid deficiency and as well as B12 deficiency. So in folic acid and as well as B12 deficiency, you will have macrocytic hypochromic anemia. But the point is, he has given you normal methylmalonic coenzyme A levels. So this will rule out, right? This will rule out B12 deficiency. Yes, Sai Tarani, what is your, you have typed it as no, sir. So can you tell me what is that, for what you have typed no? Right, so please text back me again for what you have answered, texted no, so that I will understand. So normal methylmalonic coenzyme levels will rule out your B12 deficiency. So what is left out now? The answer here is folic acid deficiency. Right, the answer to this particular question is the folic acid deficiency. I'll just show you the table also, flowchart. Now you see this is your homocysteine. Homocysteine in the presence of vitamin B12 and as well as the folic acid, it is being converted into methionine and as well as the tetrahydrofolate. Right, it is converted into tetrahydrofolate, or this particular homocysteine is converted into cystathionine in the presence of B6. Okay, your B6 is ruled out because the individual is having macrocytic anemia. Now, only thing, either it should be folic acid deficiency or your B12 deficiency. Now, how to rule out that? Now, what has been given in your question? The methylmalonyl coenzyme levels, they are normal. Now, what is this methylmalonyl coenzyme A? The vitamin B12, it will convert methylmalonyl coenzyme A to succinyl coenzyme A, and vitamin B12 also will convert homocysteine to methionine. So if there was B12 deficiency, if there was B12 deficiency, let me tell you, your methylmalonyl coenzyme A levels would have been increased. Right, your methylmalonyl coenzyme A levels would have been increased. Okay, but what is given in your question here? What is given in your question? There is normal levels of methylmalonyl coenzyme A. So that will rule out your B12 deficiency, and the answer to this particular question will be folic acid deficiency. Right, the answer will be folic acid deficiency. Right. Yes, Sai Torani Danda, if you have any objection, you can just text me so I can explain your objection to this particular question. Right. Now, yes, this is another very interesting question, and many of the students have done a mistake in this question also. Elderly patient had rigidity, bradykinesia. Sir, it was a very lengthy question, sir. I cannot recall, but these are the points which are there in the question. Which drug you will not give to the patient? Please correct me if options are incorrect. Please correct me if options are they correct or incorrect. So I just want to have a small feedback on this question. Options, whether they are correct or incorrect. Right. So let me tell you, the answer to this particular question is rivastigmine. The answer to this particular question is rivastigmine. So rivastigmine, it is a parasympathomimetic drug, right? It is a parasympathomimetic drug which is given in the dementia. Okay, which dementia it is given? It is given in case of Alzheimer's dementia, right? And it is also given in dementia secondary to Parkinsonism also. It is also given in dementia secondary to Parkinsonism. So Parkinsonism dementia, this rivastigmine can be given. But okay, so Parkinsonism dementia, we give rivastigmine. But the point is, in the clinical scenario, nowhere it is being mentioned that the patient is suffering with dementia. So majority of the symptoms were suggestive of Parkinsonism, but dementia was not mentioned. So when dementia is not mentioned, I don't require to give rivastigmine to the patient. Right? I don't require to give rivastigmine to the patient. I will give rivastigmine to the patient with the Parkinsonism if the individual has the features suggestive of dementia. Otherwise, rivastigmine is the answer for Alzheimer's dementia, not for Parkinsonism features. Okay, so please remember this question. The answer to this question is rivastigmine, and we give all these drugs. Ropinirole, it is one of the drugs which is given in patients with Parkinson's. Carbidopa, it's a peripheral decarboxylase inhibitor, and it will increase the half-life of your levodopa. And you take the anticholinergic drug that is also given for the patient with the Parkinsonism, mainly to reduce the tremors. Anticholinergic drugs are mainly given to reduce the tremors. Okay, so this is about your, the answer is rivastigmine. Next. Now, this is another very interesting question related to your acute kidney injury. Okay, so the question says that a child with urine output, how much was the urine output? 0.4 ml per kg per hour. That is the urine output of the patient. And how many hours that lasted? That lasted for nearly around 6 to 12 hours. That lasted for nearly around 6 to 12 hours. What is the KDIGO staging of the patient? Can anyone answer this question? And who will be the first person to answer this question? KDIGO stage 1, KDIGO stage 2, KDIGO stage 3, KDIGO stage 4. Right. So now let me just show you the explanation for this and come back to the question and give you the answer. Now this is the KDIGO definition of the acute kidney injury. Right? KDIGO definition for acute kidney injury. Okay. Now stage 1, the urine output will be less than 0.5 ml for 6 to 12 hours. Stage 2, the urine output will be less than 0.5 ml for more than 12 hours. Stage 3, the urine output will be less than 0.3 ml per kg per hour for more than 24 hours. Now, what is the clinical scenario which is given to us? The clinical scenario which is given to us is of stage 1. You see here, how much is the urine output? Less than 0.4. What is the duration? 6 to 12 hours. So which stage it comes under? It comes under your stage 1, right? See, in this question though, he did not give you any applied knowledge, right? This is only a question based on whether you remember your KDIGO staging of acute kidney injury or not, right? Okay, so the answer is stage 1. It is not your stage 2 or 3. Now, we will move on to the next question. So this was the question which was asked, right? And again, I am telling you, the image is not same which is given in your exam. Right? Image is not same. So the question says, a male tourist developed cyanosis of the toes after an expedition in Himalayas. Image was also attached, sir. That image was looking like cyanosis was there in the lower limbs. That was the recall which was given to me. Which of the following will not be given to him? Aspirin, oxygen, pentoxifylline, warfarin. So can anyone answer this question? Which of the following will not be given to him? Aspirin, oxygen, pentoxifylline, warfarin. Yes, you don't want to give oxygen, Sai Taruni? Acha, I think you have answered for your previous question, I think. Okay. Right, very good. So Ali Ahmed and Devaraj has answered this. Very good. So we don't require to give warfarin in this particular patient with peripheral vascular disease producing the cyanosis. Actually, what is this picture suggest you of? This picture is suggestive of your peripheral cyanosis. And this peripheral cyanosis, it is very common, right? It is very common in patients with peripheral vascular disease, for which we give antiplatelets to the individual, we give oxygen, we also give pentoxifylline, but anticoagulant warfarin is not required in this particular clinical scenario, right? The answer is D. Okay, this is another interesting question. An alcoholic developed gait abnormality, paresthesia, and many other symptoms were CNS symptoms was given, and majority of the symptoms were like suggestive of CNS, and almost 2-line symptoms were given, which I cannot recall. Which vitamin deficient the patient is having? B1 deficiency, B6 deficiency, B9 deficiency, and B12 deficiency. Now, if anyone can recall some other CNS symptoms and can tell me, that will become very easy for me to make out the answer. But otherwise, with the minimal clinical scenario which has been given to me, I am in a doubtful condition. Why? I'll tell you. See, in alcoholic patients, they can have vitamin B1 deficiency can be there, and as well as vitamin B12 deficiency can be there because of reduced nutrition. See, these patients who are alcoholic, the nutrition will be reduced in these individuals, right? So they'll have reduced food intake. So that can make the individual to have B12 deficiency also. So in this scenario, the symptoms whichever have been given to me in the question, you will have both. B1 deficiency also you can have gait abnormalities and paresthesia. B12 deficiency also you will have gait abnormalities and paresthesia. Now what I will do is I will give you the symptomatology of B1 deficiency CNS symptoms. I will give you the symptomatology of B12 in the symptoms, and then you decide what is the question given to you and what will be the answer. Because to this particular question, I did not get the complete clinical scenario. If anyone can help me in telling me the other symptoms, then it will be very easy to make out the answer to this question. Okay, so please text me if any other CNS symptoms you can recall for this question. Right, in B12 deficiency, what all the symptoms you will have is headache, muscle fatigue, balance problems, that is gait abnormality. Gait abnormality, dizziness will be there, rapid heart rate, and there will be paresthesias and tinglings in the extremities. paresthesias and tinglings in the extremities. See, based on this clinical scenario, what it looks like B12 deficiency. Right, it looks like B12 deficiency. Now, you take in B1 deficiency, that is thiamine deficiency. So in thiamine deficiency also, see, these are the clinical manifestations of your thiamine deficiency. In thiamine deficiency also, in adults, there will be ataxia, gait abnormality will be there. And in thiamine deficiency also, you can have tingling and numbness in the limbs. Right? So based on these two clinical symptoms only which is given to me, I am unable to make out what exactly is the answer, because in alcoholic patients you can have B1 deficiency and you can also have B12 deficiency. So if any of the student can recall some more CNS symptoms and give me a light on that, then it will be very easy for me to make out what is the answer. So in this, the differential diagnosis is B1 and as well as B12. I cannot make out this unless I know what are the other CNS symptoms which have been given in the question. Right. So this is another question which has been given to you. Prophylactic irradiation of the brain is done in which cancer? Right. Prophylactic irradiation of the brain is done in which cancer? Small cell carcinoma of the lung, seminoma, Hodgkin's lymphoma, and prostate cancer. So can anyone answer this question? And let me see who will be the first person to answer this question. So you take small cell carcinoma of the lung, which is also called Iot cell carcinoma. So it is a highly metastatic cancer. Right, it is highly metastatic cancer. So this highly metastatic cancer, it can easily metastasize to the brain. Right, it can easily metastasize to the brain. So prophylactic irradiation of the brain is done in case of small cell cancer of the lung or the Iot cell carcinoma. Right, so the answer to this particular question is small cell cancer of the lung. Next. Right, this also was another incomplete question. Sir, they said few symptoms of 30-year-old female and mentioned bilateral hilar lymphadenopathy in the in the question. This was the recall by some of the students and they were unable to recall the entire question. And really, I'm telling you, I feel very sorry and pity for the students who have written this particular exam. Right? Definitely, it is not the question paper that has to be given for the FMGE students. It is the question paper that has to be given for the AIMS appearing students. Right? And don't know why this particular inequality has been maintained. So that has to be really badly condemned. Right? So this is the chest X-ray showing bilateral hilar lymphadenopathy. Right? So this bilateral hilar lymphadenopathy you will see classically in patients with the sarcoidosis. Right? So you will see this in patients with the sarcoidosis. So that is what is about your bilateral hilar lymphadenopathy. Right. Now this is the next question. Vitamin D resistant rickets is due to defective calcium absorption in the kidney, defective phosphate absorption in the kidney, defective calcium and phosphate absorption, defective calcium absorption from the GIT. So can anyone answer what is the question to what is the answer to this question? And please let me know who will be the first person who will answer this question. Yes, who will be the first person to answer this question? Right. So vitamin D resistant rickets, it is nothing but it is due to defective calcium absorption from the GAT. See, what is the function of your vitamin D? The function, the physiological action of the vitamin D is to absorb the calcium from the gastrointestinal tract. right? It is to absorb the calcium from the gastrointestinal tract. So vitamin D resistant rickets is due to defective calcium absorption from the GAT. That is the answer to this particular question. Right. This is another question which has been given me as a recall. An HIV patient with CD4 count developed cough, right? How much is the CD4 count which is given? CD4 count which is given is 350. Okay, right? And the features of tuberculosis was given, sir. What will you do for the diagnosis of this tuberculosis? Okay, so first of all, let me tell you that in patients with the HIV, one of the most common opportunistic infection is your pulmonary tuberculosis. And this pulmonary tuberculosis can occur when the CD4 count is around 350. Now, how will you diagnose? What is a confirmatory diagnosis? Can anyone recall and tell me what is the fourth option? Yes, can anyone recall and tell me what is the fourth option? Okay, so if anyone can help me, what is the fourth option? That would be good. Otherwise, but the investigation of choice for pulmonary tuberculosis is CBNAT. That is cartridge-based nucleic acid amplification test. That is nothing but cartridge-based nucleic acid amplification test. Okay, so that is about your CBNAT. That is about your CBNAT. All right, then we will move on to the next question. So the investigation of choice for tuberculosis is what? That is your CBNAT, cartridge-based nucleic acid amplification test. Right. So in recurrent UTI, which drug is less effective? Ceftriaxone, levofloxacin, moxifloxacin, ofloxacin. So please correct me whether the options are correct or incorrect. Please tell me whether the options which have been given, is it correct or incorrect? And can anyone tell me what is the answer to this question? Yes, who will be the first person to answer this question? Right. So in case of recurrent UTI, the drugs what we give for UTI is nitrofurantoin. Right. We give this for chronic UTI. We also give third generation cephalosporins. And we also give the quinolones. And among the quinolones, whichever has been given to you, the options like levofloxacin, moxifloxacin, and as well as ofloxacin, you take this moxifloxacin. Moxifloxacin, it is not the drug which is given in the treatment of UTI. The moxifloxacin is the drug which is given in the treatment of respiratory pathologies. Right? And what are those respiratory disorders like where you give this particular, the moxifloxacin? This is given in the treatment of pneumonia. Right? This is given in the treatment of pneumonias. Okay. Whereas the other drugs, ceftriaxone, levofloxacin, as well as ofloxacin, can be given in recurrent UTI. Right. See, this was the other recall, but even regarding this recall also, I did not get the options correctly. The question given was, so he gave anti-HBC IgG positive. Right? He gave anti-HBC IgG positive and anti-HBs antigen positive. Envelope antigen is negative. What are the, what is the diagnosis? Acute hepatitis B, chronic hepatitis B, recovery hepatitis, the individual is immunized. Okay. Right, recovered hepatitis B. Yes. Now, the point you should remember here is anti-HBs AG positive. What does that tell? That tells the individual is either cured, the individual is either immune or there is no active disease. There is no active disease. See, this is what is the meaning of the anti-HBs AG being positive. All right, but along with that, anti-HBC IgG is positive. So please correct me with this question, what has been given correctly. Please correct me, right? You can text me. So he gave anti-HBC IgG positive. That means what? It's a chronic infection. Right? It's a chronic infection. And envelope antigen is negative. Envelope antigen negative means it is low infectivity. Right? It is low infectivity because envelope antigen is the one which will tell you about the infectivity of the individual. But envelope antigen is negative, so that tells it's a low infectivity. Now you see here, it tells that the individual is having chronic hepatitis B. The individual is not having an active disease. Why? Why? Because anti-HBs AG is positive and there is low infectivity. Why low infectivity? Because envelope antigen is negative. Because envelope antigen is negative. So this is about your serology which has been mentioned. If I am wrong regarding the question, please mention so that I will have a good recall, a proper recall regarding this question. Now you take acute hepatitis B. If acute hepatitis B should be the answer, what should be the serology that should be positive? That is IgM anti-HBC should be positive. Right? IgM anti-HBC should be positive. Then what do you mean by the word immunized? Immunized. In immunized, what should be the serology that should be positive? In case of immunized, the serology that should be positive is only anti-HBs AG will be positive. Right? Only anti-HBs AG will be positive in case of immunized. If the individual is having IgG, that tells that the individual is having chronic hepatitis B. The individual is having chronic hepatitis B. Okay. So I definitely know that there are many more questions related to medicine, but I could not get all the questions. Right? I could not get all the questions. So if some more students, if they help me in giving me a proper recall, right, of remaining questions, that would be definitely helpful for me to deliver the answers related to the other questions also, right? So with this, I just conclude the medicine recall question, but before ending, I wanted to give you one very important advice. First of all, don't get panicked, right? These clinical based questions are new for FMGE, but they are not new for the AIMS and as well as NEET PG. But let me tell you, if you can mentally prepare that you will be facing clinical based questions in your December exam and prepare accordingly, you can definitely clear the exam. The point is that you are not mentally prepared for this clinical based question in your August exam. That is the main jerk what you had. But if your mental strength and mental stamina is very strong enough that paper is going to be very tough, then you can definitely clear the exam. And remember, if you wish to have a proper preparation, you can definitely have. And it is not that nothing is impossible. Everything can be possible with appropriate, proper planning and as well as the hard work. Okay, so in order to give the advantage to the students who are appearing for the December exam, we at Arise Medical Academy are coming up with YouTube live sessions. In that YouTube live sessions, we will be discussing only clinical based questions. We will be discussing only image based questions, and they are free sessions. You need not pay for that. This is what we are doing from the Arise Medical Academy, right? And I have already said you previously also, I'm telling you now also, we will be there definitely for you for any particular fight against this particular question paper which has been given to you. So you can definitely contact us. Arise Medical Academy is definitely there for you, for your support. Dr. Khalil is very much supportive, and I am also there for you to support for any type of case, whatever you're filing, so that we will come forward and we will definitely fight for our justice. Okay, we have put our lot of effort in studying in the foreign. Okay, and if they cannot welcome us back to practice here, they shouldn't have given the permission of just going outside at all. So this is completely a injustice which has been occurred to the entire FMGE students. I definitely and badly condemn about this, right? So please don't lose your hopes. Please don't lose your hopes, right? Once you enter into medicine, in order to reach the apex of your final completely settlement, you have to face many exams. I have done my cardiology. So to the point of reaching me to the cardiology, I have written almost like 20 to 25 exams in my entire career. Okay, so you have to face many exams forward. This is just only the first exam what you have faced in India, right? So don't lose your hopes at any moment of time. And I've already said, nothing is impossible. Everything can be possible with appropriate planning and as well as the hard work, right? And again, I advise you, don't rely on cheat codes. Don't rely on mnemonics. They will just give you only a satisfaction that, okay, I remember the content, but they don't serve the purpose of making the concept. Always concept-based learning is very important. So mainly to guide you how to crack the question conceptually, we are coming up with YouTube live sessions for only clinical based questions, and I will teach you general medicine part of clinical based questions and as well as image based questions, right? So with this, I just wind up the session, right? And please don't lose the hopes. And your FMGE, one FMGE exam is not the end of your life. There is a lot way to go ahead, right? So thank you very much. And I'm very sorry and I feel very pity about the exam to all the FMGE students once again, right? Thank you very much.